What a loaded question. The answer is yes. No, I'm teasing. The way the standard of care evolves is it's what individuals think is the right thing to do in similar circumstances. I don't think you can regulate that, and I frankly don't trust regulatory agencies to come up with the right answer. I mean, I actually, in that situation, really think that it has to then fall on those who are being called upon to abide by the standard of care to say this is what's reasonable in the circumstances. And I do think there will be regional differences. There will be everything that goes into this. And so I think that in kind of building building expectations about what you should do with respect to electronically sourced information in your practice. I think physicians need to tell us what they think is the right answer. They also need to challenge us as the technical community to give them what they want. For example, in the context of the DRSA that I described, if I were a physician, I would say that really doesn't give me as much as I need. I would like someone else besides me to have skin in the game here with respect to accuracy and completeness. And so that's that also is in the mix, I think. And so that if there's a functionality standardization that could happen, which I think would be more industry than government regulation, it would be in kind of meeting the provider closer to halfway on what is being delivered to the provider for them to utilize in the practice setting. Linda, do you have a follow-up?
Yeah, Art, if I could jump in here as well. We also need to remember, especially in a large hospital environment, that today information comes in, even if it's on paper, it's incorporated into the record, and there are health information management professionals who write policy on how that information comes in, how it's incorporated. They manage the release of information. They also write the policy for what is the implication for clinicians in terms of how they use that information. So, the Professional Association, AHIMA, certainly is an authoritative source for much of this in a lot of our clinical environments and the clinical environments that have the highest rate of adoption currently. So I think that there's a lot of existing business practices that translate, and the professionals are there in place to do that translation for us as well.
One quick question, last question from, please announce yourself.
This is Laura Adams from the NeHC Board, and this, I think, is a question perhaps for Phil, but the other panelists as well. As a believer that you can never be too rich or have too much software, I was thinking about a possible business opportunity when you were describing going into practices to do audits. Is there anyone thinking about the development of software that would detect things like when data fields are coming in not filled the way that they should be, or that detect changes coming from practices? And I'm thinking more along the lines of how hard it will be to sustain what you've done after you go in and you do an audit and you correct, and then there's the drift back to old practices. Or thinking, is there anyone developing software to either do the audits electronically or help with the sustainability after audits if somebody's gone into the office?
I'm not going to answer that question first. I think you might be putting two things together, and I don't know if they're intentional or not, in terms of the validation of the data and the how do we make sure that a change sticks. And I think that's actually like you said, I remember who it was said that the software part's the easy part. It's the how do we make sure that process flows, workflows that support this data collection and validity are made and stick. That I think is going to be the hard part. And I know that some of the regional collaboratives that I've seen, they have people that are not only going out and teaching it once, but that are going out and making sure that these practices don't decay. For the question, I don't know of anybody who is actively doing what you suggest. That doesn't mean that they're not out there. I know that we're thinking about, are there ways that we can adapt the tools that we have in terms of standardized population or patient test decks and similar methods that we have to validate the systems. I think one of the other questions we're going to need to struggle with is the audits that we do are burdensome. And how do we port that down from the, hundreds of health plans to, thousands and hundreds of thousands of clinician practices that are going to be reporting this or using these systems, and doing so in a way that makes us trust the data, but it's not so crushingly burdensome that everybody goes back to paper because it's just not worth it. And so that's, I think, another part of the trade-off that we're struggling with, and I think that we're all going to need to struggle with.
Okay, one last question from Janet, please.
I actually wanted to continue commenting.
This is Janet
on this.
Corrigan.
Janet Corrigan from the board. I think Laura asked a very good question that we can try to figure out how to, develop some kind of an auditing mechanism in an ongoing or periodic way. But it strikes me there's probably two other ways to encourage proper use of the EHR, and one would be to, through the use of clinical decision support and other tools, to make it valuable to the clinician to use it properly, so they can actually, if they, those tools are triggered and they see that their care gets better and it's a good decision prompt that helps them, make the better care. I wonder too, though, these types of performance data are publicly reported and will in the future, they are now and will in the future even more, be used very extensively within payment mechanisms. And I think we probably need to give some thought in the selection of measures for public reporting and payment to measures that encourage the proper use of those drop-down menus. I mean, so for example, if you have a measure of diabetics and maybe the guideline calls for periodic assessment of the diabetic visit within some particular time period, then you might want to have a measure that triggers so that you then encourage the provider in order to get credit. If you had on record the diabetics, they would actually have to, pull down the drop-down menu and indicate that they had updated the diagnosis in the problem list and provided the appropriate care. So maybe there are ways to select measures and to structure measures that then encourage that use of the record. And presumably after you've used it, when you really get in sync with using those menus, hopefully over a period of some years, it wouldn't require nearly as much reinforcement to use it properly.
Yeah, this is Phil Runn. I want to follow up on that. That's a great point, Janet. I remember in a previous life I was supporting process improvement in an emergency department. We had an electronic patient tracking system, and I figured out how to get in the database and was putting together control charts on wait times and such, and one of the ED physicians looked at me and said, boy, well, if I knew you were going to be using it for that, I'd be using the system differently. So I think that you're absolutely right, making sure that the data is in there and usable for the clinicians so that they know why. I think that the other thing that we're going to need to balance is we want validation so that we know that the data is right, but this is it's ultimately a huge quality improvement effort, and it's really more about how do we steer the use of these systems towards best practices rather than sort of dinging those who don't use those best practices.
Thank you, Phil. Once again, I'd like to thank the panelists for coming for an excellent, thought-provoking discussion, and I really appreciate your spending the time to educate us. And I also want to thank, I do want to as well thank the staff for helping to organize this session. Thank you.
And let me add my thanks to our presenters today. We're now going to move to the nomination committee report. You are welcome to stay, but it won't have anything to do with what you just talked about. And now, we do look forward to staying in touch with you because these conversations will be ongoing for sure. person who is going to present our report today is Janet Corrigan, a board member who has chaired the nominations committee. Members of that committee have been Kevin Hutchinson and Art Davidson from our board, as well as Lily Gelinas, RN, who has been working with a NCHICA from the beginning, and Sherry Reynolds, who has also been an active participant from the consumer side from Alliance for Health. Now, Janet?
Thanks very much, John. Just to refresh your memory, the nominating committee was established in October and was given two tasks. First, to bring forward a slate of nominees to fill vacancies on the board, and then second, to bring forward a proposed slate of officers for 2010. As John indicated, the nominating committee included, why don't you go back just one time there, I want to thank my colleagues, Kevin Hutchinson, Art Davidson, Lily Gelinas, and Sherry Reynolds for the time and effort that they've put into this process and will be as we go forward. We first turned our attention to the election of new board members. And here there are currently 4 vacancies on the board. The bylaws indicate that there should be a minimum of 13 directors and a maximum of 19 directors. I do want to inform the board that the nominating committee is giving some thought to proposing a modest increase in the number of board members to probably 15 or so. We're taking a very, very close look at the depth and breadth of expertise and experience that will be needed given the direction that NCHICA is going in the future, and we'll give careful thought to the appropriate size of the board. I also want to take a second just to ask our current board members if they would please carefully examine their level of commitment to NCHICA. 2010 is going to be an absolutely critical time for this organization, and one where we really need board members who are fully committed and able to make the necessary time commitment to the organization. So if you have any concerns or reservations about that, we'd appreciate knowing immediately, because that in turn will determine the number of seats that need to be filled. Yeah. Now, in terms of the process that we're going through, on December 3rd, there was a call for nominations that was posted online, and that is open until December 25th. It's an online application, and you can either nominate yourself or a colleague. If you're going to nominate a colleague, please do check with that individual first and determine their level of interest and willingness to serve if they are appointed. Now, the week of December 28th, the Nominations Committee will be meeting by conference call, and at that time we'll be developing a provisional slate of candidates. On January 4th through 9th, the staff will be carefully vetting those individuals, doing some due diligence, and during that time period, we'll also be notifying the full board of the provisional slate of candidates that has been identified. The slate will then be posted online for public comment between the period of January 11th through 22nd. It's very important to us that this be a very transparent process and that we maximize the amount of public input, the input by the public that can be provided. And then on January 27th at the membership meeting, the NCHICA members will elect the new board members. That will be an up or down vote on the slate. And those new board members then would attend their first meeting in 2010 would be in early February. So that's the current process that we have in place for the new board members. Are there any questions on that part of our task?
Are there any questions of the board to Janet? No.
Okay. All right, then let's move on to discuss the officers, the slate of individuals that are being put forward for the officers.